Okay, so hi Jeevan, my name's Maya. I'm post F2, so I'm F3 at the moment. With regards to my MSRA revision preparation, I had a question to do with colleague misconduct. So I'm struggling with scenarios involving that. So I wanted to ask you, how do we balance being supportive to colleagues whilst also ensuring patient safety as well?
Okay, well, I'm gonna chuck the question back to you. So I'll give you a scenario that I was actually in, and I want to ask you what you do in this situation. Yeah. So I was F3 in the colorectal ward in Derby Hospital, and it's a busy ward. Our post take was about 70 patients, right? Super busy. So I was done the post take, and then went back to the ward. Had a patient who had high stoma output, and I went to just speak to her, just calculating her ins and outs in terms of the fluid balance. And then I got talking to her because you're just there and you're at the bedside. So I said, "Oh, what do you do?" And she goes, "Oh, I'm the president of TAGO UK." I said, "Sorry, what?" She goes, "I'm the president of TAGO UK." I said, "Okay." She goes, and we struck a really good relationship because she'd been on the ward for about 2 weeks, and she's like, you're literally one of my favorite doctors, and I was thinking about making just a gift to the ward, but I wanted to gift you a watch. Right, and I'm thinking, TAGO watch. This sounds incredible. I'm here for it, right? So I went back to the mess, and I spoke to my mates about it, and we were just laughing. Obviously, I didn't take the watch, right? If I had taken the watch, what would you have done?
As a colleague of yours, you mean?
Yeah, as a colleague of mine, yeah.
Well, as per the GMC, obviously there's not that culture of snitching on people, but I think the thing that I would have done is probably had a chat to you about it and ask you your reasoning behind it. Why did you take the watch? But of course, keeping everything friendly and professional, being argumentative or anything.
Okay. Now, what if after that I was like to you, well, obviously I worked really hard. I maintained this relationship with this patient. I deserve this watch. And what would you do then?
Well, I don't know whether to say it's too soon to. Well, obviously I'd carry on talking to you about it, but usually they kind of try and hint that you would speak to a clinical supervisor about things. Now, whether that's whether I'd speak to my own supervisor about it before maybe escalating to theirs type thing.
So, do you know what's really interesting, right? So in amongst that, because we've just had a chat now, it's quite uncomfortable, right, in this situation. So it's quite uncomfortable to be I'm going to actually snitch on somebody because nobody wants to be a snitch, A. And then B, like you said, you're doing the correct thing, right? You're having a chat with somebody, taking them to the side. I think another quick question to ask yourself there and then as well is, there's a relationship between me and the patient there, right? Is it in my greed or want to get this watch? I didn't take the watch, by the way, but in my want to get this watch, is there any patient safety issues that can come up there, right? Because if you're when people go into emotional states, they might be making the incorrect decisions. So is there something there that needs to be explored always, right? So kind of coming back to that previous question that we're talking about with Haj, it's about thinking about patient safety as number one. So number one, just be thinking to yourself, what's the safest thing to do here? Has he done the safest thing? I mean, it's not a cut and dry example, as most things in life are not, right? It's not like this person's got a troponin of 300 or whatever. That's not what's happening. But there are subtle differences. What if I've gone in there and I've miscalculated the stoma output and therefore I've not put the right bag of fluids? There could be small mistakes that can occur. So thinking about patient safety, I think, is the number one priority. In terms of how to address it, absolutely. It's got to be proportionate. A lot of these concepts become overlapping, right? So the proportionate thing to be doing is to, peer-to-peer, taking the person aside, explaining your rationale, exploring their concerns properly, and raising your concerns. Now, if the person is then not kind of agreeing with what you're saying, like you say, it needs to go to the next level. So, I mean, in reality, what I would do is I would say, look, I would go to my own educational supervisor to get some advice, right? We talk about this a lot, but applying something similar to the Berlin principle of understanding what the correct thing to do at that moment in time is. So thinking about that. And then moving it naturally across there where you might need to use some level of authority as well. I mean, I'm not giving the best example because it's an overlapping concept here, but then there needs to be some consequence to all of this as well. So then that's why you might need to get that person involved as well in terms of their supervisor as well. So I think with colleagues who are doing that, I think what's important is patient safety always, number one, because again, that's going to be the number one thing. And then escalating appropriately and proportionately as well, and number two. So I think that is the best way of thinking about these things. But again, I mean, as I'm saying this, I'm hoping all you guys here, can you think of examples where somebody may have done something similar to that? Probably. Not a TAGO watch, right, obviously. But there's probably other things that can be there. And also, by the way, when she showed me the value of that watch, it was £70,000, and I was like, is this something that I really actually do want for myself? I was like, no. So yeah. But yeah, did that answer your question, or have I waffled a little bit? Tell me.
It does, yeah, thank you. I had another question, if that's okay.
Go on.
Yeah. With the scenarios, like the questions, the ones to do with capacity and consent, I find them quite tricky, especially when they mention like family members when they're involved. So I wanted to ask, how do we handle disagreements between patients with capacity and their families?
It's a great question, and literally like the bane of my life at the moment as a GP. Like, Harjit will tell you the number of patients who are on my list because of these very issues. It's really hard, actually. It's really, I'll literally, my last patient of the day today is a lady who is 91, right? She's been independent for her whole life. And she's fiercely independent, and she comes in every month to see me, every month, just a kind of old school white woman, likes to have a chat with her GP, comes with her son as well. Now she's becoming a bit more frail. So in the year that I've known her, she's become a bit more frail. She also had a recent fall, and then she had a CT which showed normal pressure hydrocephalus as well. So she keeps coming in, and now she keeps she keeps calling the ambulance, and she keeps calling her son, and keeps using like the helpline, and she's not compliant at all, right? Well, every time I come to see her, every time I have a chat with her, she has capacity. And what are the 4 tenets of capacity? Does the person understand, retain, can they evaluate and communicate their decisions? That's the most important thing that I have to establish. That now, every single time I see her, we all know, I know, the son knows, and she knows that she's not safe at home by herself, but she has capacity, and that is one of the fundamental kind of compasses that we guide ourselves in medicine. So there's a huge disagreement there. The son believes that she needs to go into a home. She's got carers 4 times a day, but that's really not enough. And with normal pressure hydrocephalus, we know there's going to be a risk of falls as well. So I'm trying my best to educate her and give her an understanding of what's going on there, and also educating the son as well about why we need to respect this patient's autonomy. But it's really challenging. So how I deal with that practically is, we always assume capacity, number 1, in every situation. Number 2, you can say fortunately or unfortunately, we become mediators in these situations between the family members and also the actual patient as well. And we try to get everybody on the same page in terms of what their ICE is. I know using a lot of GP jargon, like their ideas, concerns and expectations are, aligning them as much as possible. So I think that's the principles by which I would manage disagreements in family. And it's especially in Western medicine, those basic 4 principles that we did at A-level, and everyone read that book, Medical Ethics, that small one, didn't we? Patient autonomy is super important. Like, everything is predicated on that. So if you're not doing that as a baseline, then you're going to be getting the wrong answer, because again, a lot of the GMC good medical guidance are based on those 4 basic medical principles as well. But yeah, did that answer your question? I tend to go on lots of tangents.
No, it's okay, thank you.